Happy Thursday. Yes, we are going to be recording this, so we look forward to a great conversation tonight. We have a wonderful guest speaker for you this evening, and we want to really spread the word about getting healthy and, of course, preventing or getting treatment for colorectal cancer. Unfortunately, in today's time, more and more young people are becoming affected with colorectal cancer. And it's time to have a conversation about what are some things that we can do as far as early prevention, early detection, and ways that we can seek treatment if it is something that we have been diagnosed with. So thank you guys for spending your evening with us. And we wanted to just say March is Colorectal Cancer Awareness Month. And we want to continue to raise awareness about colorectal cancer because it is the third most common cancer among both men and women in the United States. And the initiative to have colorectal cancer awareness started in 2009, and it was inspired by a stage 4 colorectal cancer survivor who urged the Colon Cancer Alliance to establish its National Recognition Day. And so for our challenge for you is to make sure that you go and tell somebody to go and talk to their doctor about their colorectal cancer risk. And so with that being said, and in the spirit of colorectal cancer, I would like to introduce our guest speaker for the evening, Dr. Valerie Lee. So Dr. Valerie Lee is an assistant professor in the Division of Gastrointestinal Cancers at the Sidney Kimmel Comprehensive Cancer Center at Johns Hopkins. She graduated summa cum laude with a BA in Biochemical Sciences from Harvard University in 2007. She then went on to receive her medical degree from Columbia University College of Physicians and Surgeons in 2011, and then remained on to complete an internship and residency in internal medicine at New York Presbyterian Columbia. In 2014, she attended Johns Hopkins to pursue her medical oncology fellowship and joined the faculty as a GI medical oncologist in July of 2016, with her primary practice at Sibley Memorial Hospital located in DC. She has a primary interest in the care of patients with gastrointestinal malignancies and has a particular interest in managing the treatment of young patients with colorectal cancer and anal cancers. Please help me welcome Dr. Valerie Lee. And Dr. Lee, before we get started, we like to think of ourselves as a family, and this is a community. So we'd love for you to share one fun fact with us and something that's about you that we remember at the end of this call.
Sure. Well, thank you so much for having me on. And I do apologize if I have a little clicking sound. I'm recovering from a cold that my kids gave to me.
Okay.
So but I guess one fun fact is being a gastrointestinal medical oncologist is that I talk about, and hopefully people will feel comfortable that we're going to talk about things like bowel movements all the time. But so my kids really try to gross me out all of the time, and they are unable to.
Kids have a way of trying to figure out a way to gross you out, and I'm
Mhm.
glad, we're built mom tough, right?
Exactly, exactly. Yeah.
And then you have the extra backup of the colorectal cancer, so you're really mom tough.
Yeah, yeah,
So
no, I tell them I talk about it all the time at work. So, body talk can affect me.
they should be tough too. I
Mhm.
see.
Yeah.
So we're going to get into this conversation about colorectal cancer, and let's start talking about prevention. When we talk about colorectal cancer, and most people think it's something that happens to older adults, and now we're seeing it happen to younger people, people that are not quite the age of like screening or even thinking about having colorectal cancer. So what are some lifestyle changes that, people on this call and we can tell our friends that we can do to reduce our risk for colorectal cancer?
Sure. I mean, I think I love that we're talking about prevention, truly, like an early detection, because, the best type of colon cancers are first, the one that never develops, and then second, the one that never needs to have you see somebody like me, a medical oncologist. I think when as you mentioned, colorectal cancer is incredibly common. We're usually thinking about it in people who are historically 50 or older. That's where the guidelines have come in, really talking about getting screening, and we'll talk about that. I'm sure we'll talk about what the screenings are. But we are starting to see more and more young people being diagnosed, and you guys have probably seen a lot of these newspaper articles and a lot of news clips that are talking about, especially increasing rates in the 20s and 30s, because that's a group that we're not screening at this point.
Exactly.
And so, I think that in terms of what causes colon cancer and what are those lifestyle things that can impact it, we know that the development of colorectal cancer is multifactorial. So, meaning that just there's many different things. So, there's genetic patterns. So, some people are much more prone to developing colorectal cancer or even just polyps, but that there's a huge impact upon our lifestyle and probably our foods, thinking about going through our gut as being a big deal for it. So, to your specific questions about sort of lifestyle things, there's been a lot of study into different things that could impact this. And the problem is that it's really hard to tease out which specifically is there. Um, we know that the Western diet, in particular, increased red meat, that's something that we think about as having and processed meats. There's a slight increased risk for that over time. And we're also just going to be thinking about sort of having lower fiber diets, those as being more challenging, but actually high fiber diets as being really protective. So one of like the best, I think, not anecdotes, but an actual study where they saw people in Japan historically have much higher rates of stomach cancer back, in the early part of 1900s. But within one generation of moving to the United States, their gastric cancer rates went down and their colon cancer rates went up. And so that's sort of like a really big indication of this Western diet probably having a big correlation with the development of colorectal cancer. But those specific things of figuring out what could actually cause it is really tough. In terms of what we can do for preventing it, we're going to be thinking like exercise and diet. Um, all those good things that you already do, probably all of us are already trying to do, are really important. And those are the few things that we've seen that really help.
And so for people that find it challenging, like, or they've already fell into that kind of risk of eating red meat,
Mhm.
is it too late to switch it and change and start, maybe reducing our red meat intake and changing that lifestyle? Does that seem to have an impact in maybe our future?
Yeah, no, I mean, I think we don't necessarily know, and that impact is still small. So I don't want you to think that just because you had a lot of bacon as a kid, that this is like the end all be all. Certainly, increasing healthier diets is known with improving. Sorry, I'm in the hospital, so if you can hear the overhead yelling at me,
No worries.
um, can contribute can help with protection. And just also in addition to that, adding, increased exercise and trying to prevent obesity and diabetes, those are all associated with better outcomes.
Okay. And so we talked about specific foods and maybe particular diets, like maybe reducing our red meat, but how important is regular exercise as it pertains to prevention?
Yeah, so there's been studies that show that exercise helps to reduce colon cancer. And so, in terms of reducing risk of polyp development, multiple small trials, it's hard to do really big studies where you're making everybody do a lot of exercise, but when they look back on it, it helps to reduce that, in part, probably also by helping reducing obesity, reducing risk of diabetes, and something we call the metabolic syndrome, which is all of that put together. That's associated with this improving and preventing colon cancer. Interestingly, even once people have had colon cancer, so if that happened, we actually find that exercise is helpful in reducing risk of cancer recurrence as well. So it's never too late to get started.
Never too late to get started. So get your steps in, audience, okay? It's getting warm outside. We have no excuses, right? And so when we talk about things like exercise and diet, those seem to be within our control. But what about things like family history and genetics? Do those weigh heavily on our risk for colorectal cancers?
Yeah, for sure. So there are some genetic inheritance syndromes. Those are actually fairly uncommon and not the main guiding force for why this, but there are those in those cases, many of these people might know about whole families that have lots of polyps or lots of um um or a strong family history of colorectal cancer. And in those cases, those are people that oftentimes will talk about screening even in childhood. But for most people, the predisposition might be more that they say, hey, my dad had a lot of polyps. My grandfather had a lot of polyps. Now, what do we do? And it's hard to tell. In most of those cases, we're not going to find a specific gene that really caused it. but we might find that it's actually probably a combination of both our genetic code, multiple genes all add together, but also that inherited what environment we're all living in, the diet that we all share together, and overall. For people who have a genetic predisposition, though, especially if you have, like, say, a first degree relative, so your mom had colon cancer at a young age, maybe at 42, then what I usually tell people is 10 years before their diagnosis, that's when you should start your colonoscopies. So it's really important when you meet with your doc to go and to let them know what your family history involves.
Okay, that's definitely good information. So I heard you say polyps. And so as we talk about polyps, what does that mean in terms of colon cancer? Is that cancer itself, or is it just the beginning? So what is a polyp?
Yeah, that's a great question. And I would say that there is all of us in medical terms sort of describe it also in different ways. And I think it can be really confusing. So usually when I talk with people about what cancer development entails, it means that, you have your regular cells lining your colon, and that over time they usually turn over. And then they can pick up mutations over time, which are just mistakes in the DNA. And while your body usually catches and fixes mistakes, sometimes the mistake sticks around and lets a cell maybe grow a little bit faster. And then it can grow a little bit faster, maybe divide a little bit more often, and then you'll have an accumulation of cells. That could be initially your polyp. And polyps come in multiple different forms. So we have ones that are completely benign or not, don't have any potential to ever transform. And then you also have some other ones that are growing a little bit more atypically, and they carry within them that potential for transformation into cancer. So those are what they look like to a gastroenterologist when they're looking at a colonoscopy, is that they look like these little bumps, or they look just like a little irregularity along the lining. And so those can be scooped out by a gastroenterologist when they're doing a colonoscopy, and we look at them under the microscope with a pathologist. I really hate the word precancer because I think that it makes, when it comes out, everybody's panicking because they think, well, I was just a step away from developing this cancer. But it is that they have the potential to then transform. And so the reason that we like doing prevention and doing these colonoscopies and these screenings is because if we can scoop those out, they can't transform.
So that's good to know. So that leads into, once we talk about prevention, the best way is early detection. So what is a way somebody can start what is the most effective screening method for one to make sure they don't have any polyps?
Yeah, so the gold standard, so the best type of screening is going to be a colonoscopy, because that's the one. And for anybody who hasn't had a colonoscopy before, I think everybody always talks about them. They seem a little bit intimidating,
Yes.
but so starting at the age of 45, it's recommended that all adults who of average risk, so you don't have a strong family history or a predisposition like in what we call inflammatory bowel disease or something, should start getting screened. And so a colonoscopy is that gold standard, but there's several other tests and we can talk about those. But what that entails is that you have to do a bowel preparation. So meaning you have to drink a lot of laxatives, clean out that gut so that the GI docs can see what's going on. People usually get some anesthesia, though some brave people will do it without anesthesia. Some good sleep that people get though. Um, and what the GI docs will do, and it's a pretty quick exam, is that they'll take a very long, thin camera and they'll insert it through the rectum, and then they'll actually just take a look straight through the entire colon all the way, and they only see the large colon. Sometimes they get a little bit of look at the small intestine. The actual test itself is pretty fast. It's mostly that all those laxatives the day beforehand that are most disruptive to everything. That's the gold standard, but I think when we were talking the other day, we were discussing that the best test is the test that you actually do.
Yeah.
So colonoscopies, we recommend to be done every 10 years. Everybody says, I hate doing that bowel prep. I don't want to do this anesthesia and have to take a day off from work to go and do this. And I'll tell you, like, the bowel preparation really only needs to start the night beforehand, and it is a day off, but of course, if it's once every 10 years, and it's for your health for all this. But
What about for those people who perhaps really can't take the day off? Are there other options for them outside of a colonoscopy that I know it's the gold standard, but that might be like a close runner-up?
Mhm. Yeah. So there's several different tests. So talking with your internist about which one is best, there is there's stool-based tests. So there's a couple of them. One is one that we say like, hey, do it every year, is where you just, again, we're going to talk a lot about stool, but is you take a sample of stool, smear it on a card, and then test to see if there's blood. So that's recommended to do yearly. And the idea is if there's a polyp, sometimes it'll produce some of that blood, but you want to check regularly. So once a year, because that whole transformation of polyp to cancer, we started thinking that whole process is about 10 years. So we want to be staying on top of it. There's also other stool tests that are sort of a little fancier where they actually look for tumor DNA in the stool. So they need a bigger sample for it.
Okay.
Again, seems a little unpleasant, but they come pre-packaged in these kits. They have everything set up for you. It can be done at home. I know it's not something that people like talking about, but
But you can
it's
go and mail it off in your privacy.
exactly. Um, you could also do maybe not the entire colonoscopy, but you could do something we call a sigmoidoscopy, which is where they just take a look at the end of the colon. That one doesn't need anesthesia, but we realize it's time off and that has to still be done every 5 years. Um, and then there's something like a lot of people have asked me about called like a CT colonoscopy, which is where you do a CT scan, which everybody's like, well, that's really fast. But in order to do that, you still need to do the bowel preparation. So it's sort of like it doesn't get you away from that. And the thing is, if any of these are positive, we still need to get that colonoscopy at the end of the day. But those are really good ways, if you're diligent about following them, to go and get them done at a regular pace. And that if they're positive, then we sort of pull the trigger to do the next one.
Okay.
Um, I should say there's really cool new studies though, and I'm sorry I like cut you off, but
No,
there
go
was
ahead.
at our most recent conference, they were just talking about what we call liquid biopsies. So a blood test to go and try and see if we could find the same tumor DNA in the blood and then help to go and use that to go and see. And so there's some that are FDA approved, but not yet recommended by national guidelines. But I would say keep a close eye on that because, a blood test, not as invasive. The problem is that so far it seems like it's usually picking up actual cancer and or
Mhm.
like more aggressive polyps. So the worry is, we don't want to miss, again, we want to try and
Right.
catch things before they become
Right.
aggressive.
But that the idea sounds so cool because it would
Yeah.
also alleviate the burden on some of, we don't have a ton of colorectal providers that or
Mhm.
gastros like in the Eastern Shore of Maryland or in the Western Shore of Maryland.
Mhm.
So sometimes people just can't get a colonoscopy without traveling very far, especially here in Maryland. So
Yeah.
I heard you talk about the age being 45 and unless you have like a family history. So what if I don't have a family history? What are some of the signs and symptoms I should look at prior to 45 that might, encourage me to talk to my doctor about potentially a diagnostic procedure?
Yeah. I mean, I think, and I don't want to say any of these things to go and scare people because I think like, most of the time when I'm going to talk about some of these symptoms, I'd say, we're going to be thinking about having somebody suddenly having a lot of, blood in their stool, having a change in the caliber of their stool. So essentially like normally have regular bowel movements. Now they're all really skinny and like it's getting harder to go and come out. So this dynamic, these changes, that's something to be thinking about. Unexplained weight loss. And then also like sort of new onset anemia, so low blood counts, which
Mhm.
is, in particular for women, something that's really challenging because a lot of us, if we're going through having our menstrual periods, a lot of us are iron deficient or have gone through pregnancy. A lot of us are anemic. And so the main thing is that like it's not usually just one symptom, and most of the time they are going to be completely benign. It's going to be hemorrhoids. Most of the time, it's going to be something, but it's worth talking to your doctor about to go and just discuss if you're having new symptoms, what might be going on so that we make sure that it's whether or not you need to get checked out.
Awesome. So when we talk about when we're talking about like our the change in our stool,
Mhm.
is there any up when it is it anything like if it's maybe you have frequent diarrhea or if you have frequent constipation, are those still things to, kind of keep in the back of your mind?
It can be, but most of it is going to be really, what does it change?
Mm.
So, like, for all of us, we're going to have a different pattern. So, for some people, having one bowel movement every 3 days is normal. Other people, they're on the clock twice a day, breakfast, get coffee, go to the bathroom in the evening. Now, as long as there's not sort of like another major life change, you've just changed your entire diet, doing all those things, a major sort of like transition for your bowels, we should be thinking, hey, what's going on? What could have caused that?
And is there any pain usually associated with maybe colorectal cancer, or is that usually not a symptom?
It can be. Usually, we're going to be thinking about sort of more these rectal cancers, and we're actually seeing a little bit more of those, especially in younger patients. So we call those left-sided. So that's where the colon sort of, sort of right side, it goes up, over, and then the stool sort of comes out and then down out the bottom. Um, those are the ones that might cause a little bit more discomfort because they're so close to the end. So people are really sort of trying to push through. Other times it's going to be a little bit more non-specific, like a lot more gas pains and feeling like a lot more bloating. Again, hard, especially in women where we have, especially as we're going through different phases of our life and hormonal changes. So don't panic that it is, but it's worth sort of checking out.
Good to know. So if we notice something that's changing over some time, bring it up to your doctors. That's a good, very good point. And so as we talk about, I'm a young person. I'm not quite 45, and I've had symptoms, and the doctor calls me in and they found something. What are my current treatment options? Like, what would I be looking at as a new patient?
So everything really depends on the stage. So if we're in a situation where unfortunately you get a colonoscopy and they find that there is a cancer, um, the first thing that they're really going to go and do is figure out sort of how invasive the cancer is. And so we do that both by the pathologist taking a look under the microscope, but then also getting a CAT scan. And colorectal cancer, the places that it likes to spread is usually, if it spreads somewhere, is the lungs, the liver, and then the abdominal cavity. And so that's a little bit different than, say, women with breast cancer or men with prostate cancer, which like to spread to the different locations. So, if you talk with other people who have different diagnoses, they might get different scans.
Yeah.
So, but surgery is usually our go-to, and our surgeons are even better and better. They have like these minimally invasive surgeries. People can be in and out of the hospital pretty quickly. And while it can be a really scary diagnosis when caught early, again, sometimes you never need to see somebody like me as a medical oncologist. For more invasive disease, so maybe something is spread to a lymph node or maybe spread to another area, surgery might still be on the table, but we'll also talk about chemotherapy. Um, but the newest advances that we've had, because the chemo has been here for a long time, is um, a lot of people have heard about immunotherapy.
Mhm.
It's a really exciting area for all of us. It works only in a small portion of colorectal cancer. We are working really hard at Hopkins to try and find other ways to get it to work. That's where we're trying to stimulate the immune system to fight the cancer. That works. So we are looking every time somebody comes in, we're evaluating, is that an option?
Right.
Um, but for majority of people, that's not an option. And we're going to be thinking about chemotherapy, but we're looking also at some things we call targeted therapies. So we're getting these called molecular profiles where we take the tumors, chop them up into little pieces, figure out what that mutation pattern is that caused this cancer to develop, and then say, hey, your cancer has maybe a mutation we see usually in breast cancer. Can we treat you with a breast cancer drug? And so each of those is like a small percentage, but when you add them all up, it makes, it's more and more people have these different options. So there are really cool things that are out there. Some of them are clinical trials, many of them are approved now. So, um, but all of this really depends on the stage of the cancer to begin with. Yeah.
And so with some of these new advancements that you speak of, how accessible are they to, like, a community like, Baltimore,
Yeah.
and the citizens that, maybe are underprivileged? So
Mhm.
how accessible are those advances to everybody?
Yeah, so actually a lot of the companies that are doing, say, the molecular testing, they are making a big push to be available to all of the oncologists across, in the United States, we have underprivileged area, but we are still very lucky in having a lot of those resources. And those companies are making a big push to have availability for all those things. So all of our patients who have more advanced cancer, early stage cancer, we don't need this kind of stuff. But and that's because they're going to be cured. We don't need to worry about all these additional tests easily. But that should be pretty standard across the board. And a lot of these things that are FDA approved and these targeted treatments, they're available very easily as well. It is hard though, finding these clinical trials, finding these new treatments sometimes. And I would say, especially in this climate where we're able to go and do telehealth, sometimes being able to get second opinions. I tell lots of my patients when they come in, it's a big diagnosis.
It
We
is.
want you to all have the information. And I realize that might be challenging, but nowadays, like I do second opinions for people who are further away, might not be able to travel, those types of things that they are available to you. Um, Clinical trials, also a lot of the major academic centers, but a lot of the community oncologists are also now participating in a lot of them as well. And so whenever possible, when we offer a clinical trial, I think a lot of people get a little nervous also because they think that we're like, oh, we're just trying something experimental. But a lot of the time it's actually because it might be a really cool new thing that we're giving.
Exactly. And I think it's important to kind of break that stigma and have people understand the connection that the community really needs to be more a part of clinical trials. So definitely thank you for pushing that message because it's I get the fear, but it's nothing to really be afraid of if we can be more informed about the decisions that we're making.
Yeah, I'd absolutely agree. And I think having a good relationship with whoever you're working with, whether it be your surgeon, your GI doc, your oncologist, um, is incredibly important so that you can feel comfortable that they're giving you all the information that you need. And if it's not the information, if you feel like you're not, then, ask, if you can. I know that's really hard, and especially when we have these visits, but that there are also all these resources, these wonderful resources available online, and these great communities that can really be helpful for things too.
You're right. And that's such a good point. And so, as a patient that is dealing with it, when we talk about resources, if I'm dealing with some of the side effects from the colorectal treatment, what are some of the things that we recommend? How does a patient manage
Mhm.
one, the diagnosis, and then two, the treatment?
Yeah. I mean, we realize, so when patients come in and see me for the first time, we call it a new patient visit. And we usually try to set aside a large amount of time because we know it's gonna be so overwhelming. Um, and I think that it's really important to make sure that you figure out for you, what are all of the resources that are going to be available to you, both from just that clinic, but whatever we can do. Um, I think there is the medical team. So like my multidisciplinary team consists of, our nurses who are going to be checking in on side effects and symptoms, our social workers who are going to be helping both with the administrative aspect, FMLA, figuring out how to take time off from work and doing all this, and how do we support that, but also are all trained counselors and helping with the emotional aspect. And we also have nutritionists, so thinking about sort of how to go and help with these different symptoms, and peer supporters, because sometimes it can't just be, it's really not us from the medical field who know. Um, but I think that the side effects of the colorectal cancer treatments really depend on where the tumor is and what treatment we're going to be doing. So somebody who has a colon cancer on the right side, when we do the surgery afterwards, actually a lot of people usually recover pretty quickly, which is wonderful, but they might deal with like the bowels changing a lot. So a nutritionist is a really wonderful person to be talking with to sort of think about how do we change the diet to go and manage things. In contrast, somebody who has a rectal cancer, that's towards the end, and that's sort of like the holding location for stool. And if we do radiation, which is a standard part of our treatment, or surgery, there's just no holding location for all the stool. And so the bowels can be really challenging. And if you radiate, that can be really hard, because we don't just treat the tumor, but we treat sort of the area all around it. And that might mean that we've affected things like the bladder or the ovaries in women and the uterus. And so that should be something that, as a medical team, that we're going to be talking about in advance, but
Okay.
also getting you guys in to see the right specialists early on. So there are these, for especially for young women like you, like if somebody needed radiation, we have these really cool things where they'll actually move, they'll do a like same day surgery where they'll like sort of just go in and then move the ovaries out of the way of the radiation site. And then that can go and help prevent women from going into menopause early. And they can protect those eggs if you need to also. So, like those are things that we should be helping you with and thinking about, and that other team members. But we also want to make sure that vaginal health is really good. And for men, that, that erectile dysfunction. So oftentimes my patients are also going to see gynecology or urology to go and help with that. Um, but so I think that there is, and then, from a symptom standpoint, we oftentimes also have a team called the palliative care team. And I say that, and I know a lot of people hear palliative care and they get really scared because they've only heard it in conjunction with something called hospice, which is thinking about end of life. But palliative care is a whole field of medicine dedicated to symptom management. And I will say, my palliative care colleagues are phenomenal, and they see lots of my patients with curative cancers, but are just having a hard time with the side effects of the treatments that we're giving them, or are having anxiety and nausea. So I think those are really wonderful. I think, you know, and I feel like I'm sorry, I'm just continuously talking. You'll never stop
Great.
if you don't stop me. Um, but like I think there's also all of these really wonderful there's online resources now, and online communities, and in-person communities as well.
Very much so.
So I think, for colorectal cancer, I always sort of tell people, like, think about Colorectal Cancer Alliance. That's a great DC based, nonprofit that sort of really gives this information. Colon Town it's a big Facebook group. They have different types of communities that really talk about it. It can be a little overwhelming sometimes because it's
Yes.
a lot of information, but it's truly peers who are going through the same process. And the nice thing is that you can digest that information on
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 your
your
time.
terms.
Yes, understood. And so like with that guidance, in your opinion, what kind of questions should a patient be asking to make sure that they're having access to all of the resources possible to them?
Yeah, so I think, certainly, first off, I know that the first visits are always really overwhelming, but I am always a list person. All of my staff and
Mm.
every patient, my family will tell you, I like to take notes. And
Me too.
I think if I don't write it down, it doesn't
It
happen.
doesn't exist.
So I'm glad you asked, because I think, coming in with the questions, so coming in a little bit is important. I think certainly asking people to sort of really list out in clear terms, like what is the plan, is very helpful. And then also, what do we expect to be side effects from each of these, and what is that timeline? And then in terms of ensuring, like, okay, now that we've seen this really systematic being, okay, if I have these things, who do I go to?
Okay.
How can I say? And then I think it is always helpful to ask, like, hey, because my patients ask me this all the time, like, if you were in my shoes, would you ask any more questions? And that's oftentimes when I'm suddenly triggered to say, oh, wait, I forgot to talk about this. Absolutely.
I might start using that one for my own self.
Yeah.
That's a good question to ask,
Yeah.
What would you ask? That's a good point.
Right. Because I think, and it's not considered, it's, and we want more questions, right? Like, we'd rather you ask the question so that we can go and help answer it, rather than somebody goes around and doesn't feel like it doesn't has the wrong information.
Exactly. I think being empowered to advocate for yourself and make informed decisions is really important. And that comes with being able to ask really good questions. And I think that's a great way to ask your provider, I think across the board, not just an oncologist, right? But it's a
Yeah.
great question to ask because you see the same things kind of over and over, and you probably hear common questions or
Hmm.
hear things that I forgot to ask, and it's something that you might see on a regular
Yeah.
basis. That is a great question to ask. And so as a community member, what is something, um, oh, one quick question from the audience.
Mhm.
Are treatments different for younger age patients because of their age?
Yeah, so it can be. So, I think unfortunately, we're not, while we wish, we don't have like unlimited numbers of treatments yet at this point. But certainly for when we're thinking about treatments, we are going to take age into consideration in some circumstances. So, like I mentioned radiation that we would go and do usually for rectal cancer. We actually had new studies that are coming out because, especially like, let's say somebody's 35 and a 35-year-old woman just diagnosed with rectal cancer, we're going to really think about, do we want to do radiation? Because our plan is to cure. If we're planning to cure, we don't want that woman to have vaginal issues, 20 years down the line. And maybe she's thinking about having kids, and how do we preserve that fertility? So there was actually a really cool study where they said, even though rectal cancer, we've always historically said needs radiation. So, like, since the 1990s, we've said everybody needs radiation. There was a big study primarily dedicated to go and trying to say, can we actually spare radiation? And they found those outcomes could be really good. Now, every case is different. Younger patients, we tend to actually be a little bit more aggressive, actually, because younger patients can handle more of the treatments a lot of the time. And even that, while somebody who's maybe 80 years old, we're going to say like, oh, a 2% benefit, maybe somebody who's 80 is going to say, well, 2% benefit at 5 years is not as meaningful to me. To somebody who is, to 40, that might very well be a little bit different. So that calculation is a little bit different, but I usually just, we tend to have a conversation about all those things earlier on.
It's
Um,
important to kind of think about, as a younger patient, it's important to kind of think about some of my desires and goals in my life to kind of help guide my treatment plan.
yeah,
Oh, we got a couple more questions in here. What
yeah.
particular steps should one take to get screened? For example, where can the screening be done? Is it a walk-in or does one
Mhm.
need to book an appointment? And does it come at a cost? Do we have centers to support screening?
Yeah. And I will say, unfortunately, as an oncologist, I'm not as set up on the pre side, but what I will say is that for the colonoscopies, which we talked about as gold standard, but is also the most time intensive, and I think, Jaleisha, you were referencing, is hard because you need to go and see a gastroenterologist. You need to have first an appointment, then a scheduling, and then and oftentimes, depending on insurance, you might need a referral even in the first place for doing that.
Correct.
For doing the stool screens, that should be something most of the time that a primary care physician should be able to go and help order for you pretty standardly. There are community outreach programs where they sort of talk about how to like where they try to do sort of mass screenings, but it's not as they're not as common, but certainly I think it's certainly something that we'd be interested in. In terms of cost, many of these, like the stool tests, the stool blood test is actually fairly inexpensive. Insurance should cover all of these, but of course, we always think about the copays that are associated with them, but they are counted as standard and should be in the screening. And in Maryland, we are lucky that Maryland has really generous and has like very great protections for patients, which I greatly appreciate as someone practicing in the area. Um, but so those should be included for all of that, but there is that copay that needs to come with it. The stool DNA tests are slightly more expensive, and so that is something that, and it's so there's a little bit more strict into exactly who is involved. So that definitely has to be prescribed. Sorry, hope that answered the question. Yeah.
I think it did, and I think it partly answered the next question. It says, do you always have to ask your doctor for a screening, or
Mhm.
should they be aware based on your age and other comorbidities?
Yeah, so I think it should be standard at the age of 45. Now, that being said, that guideline changed, in the past 6 years, I think. So a lot of docs are actually still operating at the 50 and above. And part of it is, I think is also how do we get all of that information into you in a 15-minute visit or whatever? And I fully respect primary care physicians because they are trying to do a lot of stuff in a very short time period. And so I think yes, it should be part of that list. So there's usually like we have these little checklists that are part of our system that will say, hey, we got to go this referral, we got to do this, we got to do this. Um, but I think certainly taking charge of your own health wherever possible and advocating for yourself is very helpful. And that if you feel like you didn't get that answer question, it might be saying, hey, can I set up another follow-up? Or is there a way for us to go and touch base with this? I am again, I go into my daughter's pediatrician visits coming in and I have a whole list of questions that I have asking for her specifically about every vaccine I can get for her. So yeah.
I totally understand. And like we said, if it's not written down, it does not exist.
Yeah, it's hard, right? Like we're all balancing 8 million things. So,
Exactly. So another question from the chat, is there an upper age limit for colorectal screening? If my family member is very healthy at 75 for 80, should they continue to get screened?
that is an amazing question. It's one that I keep asking my GI docs actually all of the time. So, officially, so the USPSTF, that's the US Preventative Services Task Force. I think I got that correct. Their official guidelines are that, at a certain age, we shouldn't be screening with colonoscopies. But I think this is really one where we regularly have a conversation because if you have an incredibly healthy 75-year-old who is, thinking about running another marathon, that is, and has no other health conditions, we are expecting them to live a very long time. And that's somebody who's going to be really worthwhile to just talk with a doctor about and say, hey, I'm actually in excellent health. And their likelihood of making it to their next 10 years is much higher, then it's something to at least discuss. But that definitely won't be one that they're going to sort of automatically push through. And
Okay.
interestingly, actually, the stool DNA tests, insurance won't cover for people who are above the standard screening guide a lot of the times.
So most of the times that is an automatic colonoscopy route.
Yeah, or sometimes maybe like I think you could probably get away with the stool like blood test. But again, but like that stool DNA test, because there's a couple of different ones. Yeah.
Okay. And then another question. Have you noticed anything in particular regarding colorectal cancer screening behaviors of African and Caribbean immigrants?
Yeah. I mean, I think again, I'm not on the screening side as much, so I can't comment directly, at least like what we have in our system. But we do see like there was, I think especially with like the Medicaid expansions, they were taking a look at the numbers of, and they broke it down by race, by insurance status at that point, also and by age. And they found that people of African American descent, Black Americans tended to have slightly lower rates of colon cancer screening across the board,
Mhm.
but having improved access to care improved it across the board. And so I think that was something that was with the Medicaid. This is why with the Medicaid expansion, when they saw the states that had better insurance coverage, that reduced rates was actually lowered. Now, this is a really big deal because one of the things we didn't talk about in terms of risk factors is that we do see higher rates of colorectal cancer in Black Americans, um, I believe it's in Alaskan natives as well, and I think also in Hispanics Americans as well. So I think that certainly it's something that we really need to be more mindful about. We don't necessarily change the screening guidelines for them, but it's something we should really be thinking about.
Okay. And so when it comes to being a community member, what is something that I can do to support individuals who are undergoing treatment for a colorectal cancer?
Yeah, I mean, I think that there is, I think the wonderful thing is just that so many of our patients, not the wonderful thing, but the first thing is that a lot of my patients, when they come in, they oftentimes feel so alone. And they have their loved ones that are with them, but it feels like, oh gosh, I can't tell anyone because they're worried that people will judge them and that they'll
Yeah.
say, well, why did you get this cancer? Or this seems like such a burden. And I think that sort of providing support, so whether it's emotional support, because realize, I think, but just saying like, hey, I'm here for you. I'm willing to talk. Like people have said, like, that's really a big deal. I think there's a lot of visits that are oftentimes involved. And sometimes, if it can be that there is, do you need somebody to help drive you to another appointment? Do you need somebody to just be there on call for you? Like that's sometimes some things. Um, and then also knowing, so I think being that type of support, spiritual support, I think a lot of people find incredibly helpful. I think also knowing that the journey is long. So a lot of times people get a lot of support at the very beginning, but even with advanced colorectal cancer, I'm hoping that people, which maybe I can't cure, and there are cases where we have that, this is maybe sometimes a 3-year journey, and a lot of people find that it's hard to, and it's not to say that people need to be that because we can't always give all of ourselves, but making sure
Mhm.
that if you are checking in on people throughout their journey regularly throughout that process, that can be that's helpful.
It's very helpful. Very much, very true. And so, what are some of the common misconceptions about colorectal cancer? Let's dispel some myths.
Yeah, I mean, I think the most common thing that people think about when they come in is that, what did I do? I caused this cancer. And I think that is the number one thing. There's a lot of guilt and a lot of worry that people say that I didn't eat well, I didn't exercise well. There are people who have come in and have been worried that this is a sexually transmitted sort of infection that could have triggered all of these things. This is Colorectal cancer is incredibly common. It is just incredibly common, and it
Mhm.
is something that can happen to all, really, unfortunately, to many different ages and to both genders and to all, like, to races, like across the board. This is something we really need to think about. It's just that it's common and it is not a fault. And so that we want to sort of dispel that guilt wherever we can. Yeah.
That's a good one because I think sometimes it's really easy to internalize the things that happen to us as and we try to go down all of the list of bad things and bad decisions we've made and oh I
Mm.
shouldn't have eaten that or and I think that it's good to know that a lot of the times we don't really know why the cancer even was here. We know what we can do to try to prevent it from starting, but we don't know why it developed in the first place. And I think learning to not blame yourself is a great place to start.
Yeah, absolutely. And I think that it is, and even when and I have some people also who say, like, oh, they didn't get their colonoscopy and it was their first time and they found it. And, if we can, when we go in, whenever somebody comes in and says, well, now we know, that's all. Those sort of looking back in the past, as someone who sort of internalizes and sort of like thinks about everything, it's not helpful. And really the best way is just going looking forward and how we can go and treat things.
And so, as caregivers, as friends and loved ones, and as a provider, what are some things that we can do to increase this, like, to combat, what people, these misconceptions about colorectal cancer, especially like you did something? What are
Yeah.
some things that we can raise awareness, I guess, to make people feel more empowered?
Yeah, I mean, I think more education. So I'm so glad that there are people taking an hour out of their incredibly busy lives to even be thinking about this. It's great. But I think, that is so it's spending that time and sort of taking that time to be educated and then encouraging others to, just to have that knowledge. And I think part of it is again just saying this is common. It is incredibly common. It is something we can screen for and something we can really try and prevent. Is sort of the big takeaways, I think, certainly for that, both as loved ones, as caregivers, and then dispelling that, once something happens, is that these things happen. And if it happens, it's okay, it's not fault. It's but it's something we can deal with and something we can treat.
Yes, and the good thing is that medicine is making some wonderful advances so that we can really start to nip cancer in the bud soon. I hope, fingers crossed, right?
Yeah. Exactly, exactly. I mean, I think it's a multifaceted, but there's really cool stuff that's out there. And, I think, some of these other cancer types, like, the docs are just walking around, they're like, I've just got all my 10-year follow-ups right now. And I love that. And we're hoping for all this. So,
That is awesome. So we have about 6 minutes left. If there are any more questions, please put them in the chat at this time. And I would like to say, first of all, thank you so much, Dr. Lee. I think that this was an incredible conversation. You were so personable and very easy to understand. If you could leave us with one piece of wisdom from your profession, what would that be?
oh gosh. Well, that was tough. Maybe someone wants to come up with other easier questions for me right now. Um, and
I
I
do have two in here. If you, oh, somebody said,
oh,
excellent information. Thank you so
oh.
much.
I appreciate that. You haven't saved me yet from coming up with words of wisdom. I mean, I mean,
Exist.
I think at this point is really just that, I think, our life is short, life is precious. Let's try and see every way that we can keep you healthy, keep you around for as much time as possible. But if things happen, there are really cool treatments that we can go and do across the board and help manage it.
Well, thank you so much, Dr. Lee. You're right. It's taking care of yourself. And thank you for one, helping us raise awareness of colorectal cancer and helping everybody talk about getting screened and having this conversation about what we can look for, early detection. And if you haven't started your New Year's resolution of eating well and exercising, it's never too late to start. So once again, thank you so much. If you were registered, I am going to be sending out a a link for a survey. So I would love if you guys could participate and just let us know what you thought and how we can improve. Dr. Lee, once again, thank you. And we are signing off now.
Great. Thank you so much.
Right.